Okay, so this is the title of my presentation. It's based off a paper that was recently published. I'm presenting on behalf of my co-authors on the slide here. This study is part of my PhD, which I'm in the last 1 or 2 months of finishing, which is really exciting. And it's been, thank you. Well, I haven't made it yet, so let's cross fingers and toes. But thank you so much for the privilege. I really mean it. I'm going to get a bit emotional, but meeting you all in person, seeing many of you on Zoom or emailing with you, it's been really special. And being here in Boston, I do want to highlight that the work was done all across the world online, but we were based in Melbourne in Australia. Some of us have come a long way. And this work was done on the land of our native peoples there, the Wurundjeri people of the Kulin Nation. Okay, so when I get into my presentation, I'm going to give you a bit of background. Some of you might already know this, so excuse me if you already do. You can just phase out and phase back in again in a couple of slides. But speech and language are terms that are often used interchangeably, but they're in fact distinct different things. And I forgive anybody who gets them mixed up because speech pathologists are really the only people who are sticklers about this, but I think it's important to describe the challenges we might be seeing in individuals with KAND. So speech is the sounds we make when we talk. These can be measured with milestones. So for example, we get our B and our P sound well before we get our R and our Th sound in English. And if you have difficulties with the sound of your talking, you might meet criteria for a speech disorder diagnosis. And there's a list of some common diagnoses on the slide here and also some more rare ones. So the one that's second from the bottom, dysarthria, is very, very rare in the general population of children. And I'm going to explain that more on the next slide because that's of particular relevance to individuals with KAND. And our language, on the other hand, is our vocabulary and our grammar that we know and use. So I always give the example when I got my wisdom teeth out when I was a child, I couldn't speak, but my language was intact. I could understand everything and I could create grammatically correct sentences in my head, or I could write them down. I could use other ways of communicating that language. And so we heard this described before. Receptive language, our ability to understand, and expressive language, our ability to communicate an idea. So that's speech and language when I refer to them later. Dysarthria is a motor speech disorder, and KAND is a motor condition, so it's not surprising we would see a motor speech disorder. So this disorder can affect different parts of speech. So our ability to have enough breath support or respiration, our ability to make sounds with our vocal folds, particularly when we're dealing with things like spasticity, resonance, so sounding hypernasal, or quite nasally, prosody, so stress on different words, and then the last piece, articulation, so actually making the sounds with our mouths. And so you can have a breakdown in one or more of these systems, which can make an individual tricky to understand. And dysarthria can be very, very mild, so maybe only I would notice, because that's what I'm listening for, or it can be quite severe. So it's very difficult to understand somebody and be quite frustrating. Okay, so with that, as part of our study, we did a list of assessments which you can see here, and thank you so much to the families who had the patience to do them all. I want to focus on just a few of these areas today, but I just want to highlight that if you think I'm missing something major, because you've read the paper, I'm just doing it in the interest of time for today. And if you hear me refer to the term AAC, which is a very unfriendly term, augmentative and alternative communication, this is what I mean. It's a system to communicate that's anything other than speech. And I'll be talking about symbolic communication today, or AAC. So that can be unaided, does not use an external system, just uses our body. So for example, in Australian keyword sign, this is more. In the US, it's this, I think. Someone correct me if I'm wrong. And aided uses an external system, which can be low tech, so non-electronic, or high tech, which is electronic. So I want to provide a little bit of a background. I don't really need to explain, obviously, KIF 1A to this group of particular people, and also a lot of this background's already kindly been covered, but I just do want to frame that. Obviously, it's such a heterogeneous condition, as all of you know, so naturally the speech and language outcomes that we found in this study are very heterogeneous, and it was really based on variant type. We could see when we had, as Dr. Wendy Chung spoke before, when we had many individuals with the same genetic change that helped us see these patterns in our group. And speaking about how this project came about, I think is really important. So Dr. Simran at MCRI, she'd speaking to Australian families, and they said to her, communication is really important. And when Dr. Wendy Chung put up the 3 main core issues for families on the slide before. You saw communicate. This fit well with my, because I was like, if no one writes speech or communication, this is really not going to work well for me. But thank you all for writing speech and communication as your top 3 issues that you really are important to you, because that's what the Australian families said to SIM. And then my team that I work with in MCRI in Australia, our specialty is genetics of speech and language. So I have an undergrad in genetics. I went and did my master's in speech pathology, and now I'm finishing up my PhD at the moment. And as a very heterogeneous condition, we had case studies and case series where speech and language was kind of described or mentioned. And then we've got lovely phenotyping and large cohorts through, for example, the koala study. And speech and language is incorporated, but it's obviously not the focus because those studies are capturing so much information. So this study was looking very specifically at communication, and parents had told us it was important. So our cohort had 44 individuals. Dylan said that's very kind that we did it quite quickly. The only reason we did it quite quickly is because families gave me everything really, really quickly, much quicker than I thought, which was really helpful. As you've heard before, our average age was very, very young. We did have a lot of adolescents and adults, but really the majority of our group was quite young, just for the nature of people who were getting a genetic diagnosis. Vast majority of the participants who took part were English speakers, but we did have some individuals from other countries take part, some of who I've met here, which is fantastic. Because KAND is obviously so rare and Australia is so far away, we had to make the whole assessment battery online. Okay, so I'm not going to speak too much to this slide, but I just want to highlight that we had the majority of individuals in our group have a KIF1A variant or gene change in the motor domain of KIF1A, a missense change. And you can see here that I love that term that Dr. Wendy Chung used, those skyscrapers, so individuals that are sharing the same variant. And we had a smallish group, but pretty big still for a rare condition. And so these are our skyscraper variants, our recurrent variants. And you can see on the right-hand side, this very simple colour coding, it's a picture from the paper, that those individuals have higher support needs, more things they need help with than the individuals generally speaking on the left. And also, of course, these people are of different ages and things, but you can already see that pattern from the colour coding. And there's been some recent functional research which has shown us that the KIF1A protein's ability to walk along the microtubule is more challenging for those variants which have more red and orange than it is for the variants that are on the other side that have more lighter colours like green. Across the group as a whole, when I show you these graphs, I know it's a little bit tricky to see, but the middle thicker dotted line is where the majority of the group is sitting. And you can see the Vineland measure. As we said before, it's a wonder. I like it as a measure because you can use it for anybody, any age, anywhere. It's online, although I appreciate it's a nightmare to fill in. It's so long. But thank you so much for filling it out. And you can see here that this is the average range, if you like, and the majority of our group was sitting below average, but there were some individuals who were in the average range. We only had one individual in this group who had average communication skills overall. Those little stars you can see, and this is what we've heard time and time again anecdotally, is that individuals with KAND are extremely socially motivated. And caregivers also shared some anecdotal information, things like loving music, loving water, which we've heard today, being extremely persistent and extremely resilient. And I think an objective measure like this, capturing what you guys are saying to us anecdotally, is really helpful, because I think just as a therapist, I work clinically as a speech pathologist as well. And if I knew that about a kid I was working with from the outset, that'd be really helpful to know where I can push and challenge and support other areas of weakness or where we need more support clinically. And then looking at communication specifically, an individual's ability to express themselves was much stronger as the group as a whole than an individual's ability to understand. That's as a group as a whole. Of course, individuals, they might have differences themselves, but I do want to highlight as well what Caitlin said about Nora is that there's a lot of confounding factors. There's vision, there's behaviour, there's attention, which might be affecting someone's ability to understand an instruction or understand a question, or they might just echo back what they've been asked or told. And that doesn't necessarily mean they don't understand, but it might be perceived that they don't understand as well. So I think that needs further exploration. And again, we had some individuals in that average highlighted range, but most of the cohort sat below average. And in terms of language development, I'm not going to speak about this as much today in our presentation, but it's in the paper. overall, 80% of the cohort had delayed for age at first words and delayed age at combining words into sentences. Some individuals were learning those skills. So typical development, we see that by the age of 2 years. Some parents were reporting at 8, 9, 10 years of age. So I think it's also good to, and I had one family who told me that their young person started combining words into sentences at 20. So obviously that is helpful and unhelpful, not knowing what the future looks like for your young person. But I think that piece that most people are going to be late to talk, and then some other things I'm going to speak about in terms of speech later, we need to find other ways to support an individual's communication development given that information. We also looked at social responsiveness. So this measures kind of a pain because it's flipped around. So if you have a score down the bottom, that's WNL, or within normal limits, average, and then higher scores, you have higher challenges. And I just want to highlight that on this tool too, we saw that most individuals had challenges across all of these different social communication skills. But overall, on average, individuals had average social motivation ability. This was a relative strength. It was statistically significantly different than every other skill that this tool measured. So that was nice. That mirrored the Vineland results. That mirrored what you guys were telling us as well. On to speech, so the sounds we make when we talk. A perceptual speech assessment is a speech pathologist like me listening to you talk and rating different speech features. Everybody who participated in the study had dysarthria, that motor speech disorder. But for some individuals, it was very mild. For some individuals, it was more severe, and it impacted their intelligibility or their ability to be understood a lot more. You can see a list here of the common speech features, and you can see that lots of different speech areas were affected. So people had more difficulty changing their pitch, changing their loudness. There were more harsh vocal tones, more nasal speech, more difficulty with stress. And all of these things essentially culminate in sometimes some individuals being tricky to understand. For some, it's very, very mild. And we also had some anecdotal reports from those older individuals that these things had progressed as they got older. And I think that's something that will be interesting to see in future research as well. And we also did have 22% of the cohort caregivers told us that there'd been some speech and language regression. We just based that off that caregiver report because this study was one snapshot in time. But I also do want to highlight regression of speech and language skills occurs in many autistic children, about 1 in 3 of autistic children. It also can occur in typical development too. And so because we just got that wonderful caregiver report, I think in future it'd be nice to actually distill what is KAND specific speech and language regression rather than something that might be associated with lots of other things going on for any young person, let alone one with KAND. And this is an acoustic speech assessment. So I look at your child's sound waves like a DJ, and I compare their sound waves of their speech to 2 age and sex match control participants per individual with KAND. And these are objective measures which tell me about their speech. So it's not based on me just listening, it's also based on those objective numbers. And essentially, this is rather a busy figure. And for those of you who met me on Zoom and I made your children say pataka, pataka, pataka and all those things, that's what I was doing this for. And so despite the heterogeneous nature of KAND, objective acoustic analysis showed distinct clinically and statistically significant differences between individuals with KAND and those without. And that manifested in perceptually slow and effortful speech. And what is interesting is these kind of measures are being used in adult onset dementias, adult progressive conditions, for example, to show response to medications or even to show how fatigued you are. And I think your kids, I didn't traumatize them. I think it's pretty fun to do. And it can be done remotely like I did with you guys on Zoom. So I think it's an interesting space. It's starting to be done in clinical trials in adult populations. And it was nice to see that for some of our kids who are speaking with KAND, that this was maybe something that we could do in future. And so for our children and young people and adults who weren't using connected speech to communicate, I just want to briefly speak to, we didn't just give up and not assess their communication, because as Caitlin wonderfully said before with Nora, we have to pick up on communication that is not just words. It's behaviour, it's vocalisations, it's facial expressions. And so this tool assesses communication of a range of different behaviours across 4 communicative functions. So refusing, information, obtain and social. And I think it was interesting when people said some young people can't say when they're in pain. that reflects here that only 16% of this group of individuals could make comments about their feelings. So they couldn't make a comment, hey, I'm in pain, or I'm feeling this way. And so I think as speech pathologists, for example, or as families, this would be interesting to kind of delineate. I think I know clinically it's very easy to teach someone to ask for more for something or ask no, but our kids are pretty good at doing that. The most could do that. And so maybe we need to look at those areas that are more challenging. In terms of augmentative and alternative communication, or AAC, about half the group have been exposed to AAC with different levels of proficiency. Obviously, the motor and vision implications of KAND made this extremely difficult, let alone learning AAC is hard. And you as parents have an awful lot on. And it's like learning a whole new language. We did see that aided AAC tended to be introduced when kids started school. I would like to say that maybe it should be included earlier because we know kids are really good at learning language when they're younger. So it'd be nice to capitalise on that early language learning period. But of course, I'm biased. And we also saw that some caregivers believed the misconception that AAC hinders speech development. And I guess if there's one takeaway today, it's proven that it does not. It does not hinder speech. It can help with our language skills, our grammar skills, our literacy skills, our social connectedness, and there is even preliminary research to show that can really aid speech development as well. And so I think as clinicians, as speech pathologists, as paediatricians, GPs, it's our responsibility to make sure that information is passed on. So what do we know now based on this study? Just a little snapshot, that we saw some genotype-phenotype correlations, so the gene reflecting the characteristics of an individual that were kind of mirroring what we've been seeing in other studies. We saw that dysarthria was common, and that is, those acoustic speech features really differentiated individuals with KAND in this group with control individuals. And again, I have to say I'm biased because obviously speech and language is my bit, but I think it would be really interesting to look at like objective measures. We could say objectively this person's speech is getting clearer and faster and easy to understand. And because it's kind of like you could do a 2-minute voice recording very quickly and very easily, it can be gamified and quite fun. Language and cognition really range throughout the group. Social motivation is a strength, we all know this. And AAC, I think it's important. We still got to nut this out. It is challenging. Vision and motor impairments are challenging, particularly with AAC. I think we have a long way to go, not just in KAND, but I work in other genetic conditions with vision and motor impairment, and this is not yet perfect. And I think early intervention needs to be considered because individuals might use AAC and then they kind of might graduate out and not need it, or they might come back to using it, for example, when they're an adult if their speech becomes a bit unclear, and they can use it as an emergency backup if you like. Sorry, I don't know where I'm at with time-wise. I've actually just completely not even looked at the clock. I apologise. Okay, so resources, we've made a few on our website, both specific to this study, a plain language summary. I've got QR codes on the next page, and a little summary of speech and language in KAND, so you can print those off, for example, and give them to your teachers. Here are the QR codes. I really hope they work. If they don't, you can email me. I really want to thank, again, the families. If I had started this out and no one had wanted to take part and do all these things generously in your spare time, I wouldn't have a study. And that's been such a pleasure to work with you all. I want to say thank you to my co-authors who all have different areas of expertise who've assisted with this study, particularly my 2 PhD supervisors who couldn't be here today, Professor Angela Morgan and Professor Ingrid Schaffer. And there are QR codes on the slide there. I'll just leave that up for a moment. Yeah, thank you.
So we'll be taking a couple of questions and perspectives, so I invite anybody to chime in as they feel. I did want to start off with one question because you mentioned having just a 2-minute video would be able to give you some tools to assess the speech and its potential improvement. And I think we think about these endpoints a lot. And something we've talked about is are there video recordings we could take of kids just like on an ad hoc basis and start to use that for our own assessments? How standardized do you think that would be? Is there some 2-minute script that we would want to run people through, or can it be pretty variable based on what they're talking about?
So that's a really good question. This is a very new space. With adults, obviously, we can just give them a standardized script to read. We say, read this thing, tell us about your day for 2 minutes. It's very easy to standardize things for adults. It's more tricky. So some of our adults with KAND would be able to do that fine. Some with kids, there's more exploratory measures, getting the parent. I think often in hindsight, doing this study, I should have gotten the family. I just was selfish and wanted to meet everyone. I should have gotten the family to do it on their own with their child, because your child isn't communicating how they normally would with a complete stranger, even though I tried my very best to be friendly. I think, especially given the vision impairment element, I know for some kids it was a bit confronting because they couldn't see me properly and it seemed a bit stressful. So yes, long story short, there are play measures that have been done in some kids with, for example, Niemann-Pick type C that are starting to be explored, GLUT1, and they're play-based speech measures that can be done at home for 2 to 5 minutes at home. And they're recordings and also video recordings. So it's, exploratory space, and the individuals are compared back to themselves, which I think is helpful, or to age and sex match controls, which I think is helpful given the heterogeneity of KAND. Having this one standard score wouldn't necessarily be appropriate. It's more comparing an individual back to themselves, for example, before a treatment has started. Yeah.
Any other questions or thoughts?
Thank you for all this research. It's super interesting to see what some of the trends are across KAND. Given some of the, I should say too, hi everyone, I'm Ashira, I'm Athena's sister. Given some of the issues that you identified in speech throughout all the individuals that participated, are there any specific types of therapies that would be more beneficial than others to help address some of these issues?
That is a big question, and I think we can move that way. I think from the outset, I know working clinically, and I'm not here to bash all speech pathologists because I think they're wonderful, but I think I'm in a privileged position where I have had that genetics training, and I think as speech pathologists and as parents, we need to advocate that it's really important to understand a condition and understand what the future might look like and what other things a family is dealing with. Like families were getting prescribed AAC, that was just far too burdensome with everything they were dealing with at that time and not consulting with parents about what's realistic. So that's, I think, a real piece that I think more broadly we need to advocate for allied health professionals and people who aren't medical doctors to have an understanding of genetic conditions. So that's one piece. The dysarthria that I mentioned before, there are starting to be trials in populations that have dysarthria, for example, like cerebral palsy or children who've had a traumatic brain injury. There are no trials yet in individuals with genetic conditions which cause dysarthria, although there are some of my colleagues who are working on those in my team in other genetic conditions. So I think what was said before and said in previous talks, trying to borrow interventions that may or may not be helpful. So I know there's one golden thing. I think also families, this research was just a snapshot, but I think families sharing what has and hasn't worked, why not, and collating that information will be really helpful in future, so that, for example, if something didn't work for XYZ reason, or you wished in hindsight you did something earlier or differently, I think that would be really helpful to capture from a research perspective to collate that information for families, but I didn't do that in this study, unfortunately. I know that wasn't a very specific answer, sorry.
Hi, this is kind of like a out of the blue question, but I'm also really interested in speech and the whole subject. What is your opinion on like Braille within language and communication within the KAND community?
That's an excellent question. So about Braille, I've seen individuals with a very, very severe involved childhood dementia called CLN3 disease, a type of Batten disease, learn Braille. And I think obviously it's tricky, it's challenging to learn Braille. I don't know Braille, must be honest, but I do think it's worth a go and worth, I think as been said before, our kids can surprise us, and even just borrowing from some of the concepts of Braille. So Caitlin mentioned before using tactile objects. There are different 3D printed objects and symbols that can be utilised, so for individuals with higher support needs. And I think learning Braille is absolutely something it would be fascinating to study in a population like individuals with KAND. I definitely think it's worth a shot because I have seen individuals learn Braille who I just thought they couldn't, to be honest, and they have. And who have a really quite steep decline and they've been able to learn it. So I think that's a clinical perspective, not based on any data, just my opinion. But yeah, that's an excellent question.
Charlotte, I know for Nora, they have started introducing Braille.
Oh, amazing.
That's really cool. Thanks.
That's cool. If I did this study again, I should have asked specifically about that. Yeah. Awesome.
So my speech pathologist knows that I'm here at the conference, and she asked me to gather any information that would help her. Do you feel that this, like the fact sheet and the study, would be the best thing to provide to her?
Yes, absolutely. I think that would be the best place to start for her to read them. And then she's more than welcome to email us if she has particular questions. We have families, clinicians do that all the time. They'll read the study and be like, oh, I had a question about this, or I wasn't so sure about this, or that's completely fine. So speech pathologists email my supervisor and head of our team, Angela, and myself all the time with those questions after they've kind of read the study and get the lay of the land, because if they haven't done that first, then I'll probably just end up sending it to them and say, read it and then get back to me, because that study might answer the questions that she already has. There's quite a lot of information in there, and I just touched on a bit today. But yeah.
Thank you.
Has anybody tried a type of therapy or something that has made gains in terms of speech or communication? Anecdotally. Seems like this is a big area for growth.
Yes.
Oh,
So I appreciate you mentioning with the sign language, or the whatever the verbiage, how you associated that. My nanny at the time, she taught Riley that as she started to see, and now she's a child life specialist. But she saw that and she taught her that. My concern was that it limited her progression and actually expressing language, because she still uses like more and things as she says it. So I appreciate you providing that information, but that has helped her doing some of the signing to where she doesn't get as frustrated, even at like such a young age, with me when I couldn't understand her. Like she just, what I call babble, like when she doesn't have a word for it.
Yeah, absolutely. So I think keyword sign, which is, I know it's called slightly Makaton, baby sign, it has like some different terms around the world. It's not sign language per se, because you do it as you're speaking, as you described. So it's really there to supplement speech. It's not a separate language like sign language is with its own grammar system, but we borrow signs from sign language. And so because that child, for example, when I'm saying more or more, they're getting just as much speech modelling as they already would or ordinarily would. But speech is the hardest motor skill we learn how to do. I think it's something like 100 muscles involved in speech or something. So no wonder it's challenging. So for an individual, when they're feeling overwhelmed, or they might be physically unwell, or when they're still learning to speak, or maybe they won't learn to speak, doing something like a more is going to be easier than saying more. And it also is a way to introduce different vocabulary and grammar. It's quite salient as well. You're seeing something, you're hearing something, you're getting multiple cues about the vocabulary itself. So I think it is a really helpful tool. I know in some, that sounds amazing, you had such a lovely nanny. And we also, for example, in kindergartens in Australia, they're starting to just introduce it to the whole class, because kids from many different walks of life benefit from having a visual as well as a spoken model of anything.
Hi, I have a quick question. Have you ever worked with or considered vocal cord paresis? Because that's a symptom of a lot of KAND patients, or at least some of them.
Yeah. Yes, so the question about vocal cord paresis, I personally haven't worked in that more medical space with vocal cord paresis. I know it's difficult because it's something that's well understood in adult populations. For example, individuals who've had stroke, which have affected one side of their vocal fold, so it's just not working and meeting the other one. That's what we need to make sound. So I think absolutely it's a space that needs to be explored in KAND. The current medical treatments and behavioural treatments that are out there, things like putting Botox in the other vocal fold, or behavioural measures like turning your head when you're speaking to make them close up, they're things that have only been tried in adult populations. So it's something I personally have personal clinical experience with, but it's also not something that's been well explored in the literature that this at all in kids. Yeah.
thanks for bringing that up. All right, I'd like to give a huge thanks to Lottie Morison for joining us.
Thank you.